Okay. Good afternoon, everyone. My name is Noelle Derman, and I am the Director for Hospice Giving for the Goodwin Living Foundation. And welcome to our panel on advanced care planning. This is part of our lineup of events for National Hospice and Palliative Care Month. And we are putting on a bunch of different talks to really give more information about the resources that exist here at Goodwin Living and out in the community some more. So the theme for this month is We See the Whole You, and that is perfect for Goodwin Living and Goodwin Hospice because there is such a focus on serving the person and what matters most to them. And today's panel touches on that. It touches on how to start thinking about what matters most to you and how you want to make that known for yourself and get your papers in order, but also for your family and friends. So we have two wonderful speakers today. We have Erin and we have Jen. Erin is the manager of our Care Connections program, and Jen Crane is an elder law attorney. So they're going to come up and talk pretty briefly and go over the real basics, and then we'll have lots of time for Q&A. So come on up, and they'll introduce themselves a little bit more.
Thank you so much. Hello, everyone. It's so good to see everyone. Thank you for coming to our panel. Like Noelle said, my name's Erin. I'm the manager of our Care Connections program here at Goodwin Living. Care Connections is our palliative service. We had a more traditional palliative service that was really provider-driven with some nurse practitioners and some nurses that were really focusing on symptom management and kind of medication management for people. And when we thought about and asked the residents what was most important to you all in terms of palliative care, the answer was really more around advanced care planning and talking about medical goals for care. And so when we brought this model back, it really is a social work model at this point. It is myself and two other social workers, and our main goal is to meet with anyone that would like to meet with us, but generally people that have a chronic condition. So something that's not going to go away. It could be COPD, it could be cancer, it could be advanced heart disease. And we want to make sure that we understand as an organization, and sometimes as your medical providers, if you use Goodwin Living as your primary care, what is most important to you? What are the things that you are open to medically? Are there any things that you are not open to medically? And how do we make sure that those choices that you've made are respected by your medical providers? So our main goal when we meet with people is to ask all of those questions, to say, what is your diagnosis? How have you been feeling? What are your symptoms? What are the things that you would like or would not like us to do medically for you? And from that conversation, we can really steer people towards the resources and supports that make the most sense for you. We want it to feel like a very individualized process. Your health journey, you actually have a lot more control over your health journey and choices than you might realize. And we're going to talk about some of those choices today. And as we know that people with chronic conditions, those conditions that don't go away are likely to progress or at least change over time. We want to make sure we're kind of checking in with you periodically at kind of a regular interval from our perspective, or if something has changed from your perspective, if you have a new diagnosis, if your symptoms are really increasing, if you're feeling better, we want to make sure that we're following up with you at kind of every step of the way so that if those resources change, we can kind of swiftly adjust and make sure that you're connected to those things. So that is kind of in general what we are trying to do with our palliative service here. And I think one of the main questions I get a lot is kind of how palliative care and hospice are either the same or different. And I think the easiest way to think about it is that philosophically, hospice and palliative care are trying to accomplish the same thing, right? We're trying to accomplish symptom management, pain management, and maintain your comfort and your quality of life. Now, which one you choose or which one kind of chooses you is a little bit of a different story. Palliative care at Goodwin Living through Care Connections is really open to anybody. You don't even necessarily have to have a chronic condition, but if you want to talk about your medical choices, if you want to talk about some of the documents that we find really helpful to have that help us know who your medical powers of attorney are, what your code status is. We can help with all of those sorts of things. Hospice, on the other hand, is actually an insurance benefit. And so, as you can imagine, there's some bureaucracy around who can access hospice and how you can access hospice. I'll talk a little bit more about that later, but that's generally the main difference between the two. We're always looking at quality of life and comfort. But if you're eligible for hospice and your goal really is comfort, maximizing comfort where you live, and kind of avoiding some restorative or curative treatments, hospice is probably the best way to do that. And a lot of palliative services, including Care Connections, will talk about hospice as a resource if it feels appropriate. Some people get a referral from their physician to say, hey, you should really talk to somebody about hospice. Some other people independently say, hey, I just want to know more about it. I want to have what we would call an informational visit about hospice, just to really understand what are the criteria, when might I access hospice, what does it look like, is it different in independent living as opposed to assisted living or in the small houses? And so we are happy to have that conversation with anyone really at any time. Now, code status, just quick show of hands, who in the room knows what their code status is right now today?
What's code status?
Code status, great question. What is code status? Code status is really talking about CPR or attempting to resuscitate somebody. And so it's one of the things in the medical field where if you've not actively made a decision about your code status, one has been made for you already. And so everyone in this room has an established code status. You just might not have participated as intimately as you would like to. And so I could talk about code status all day. It really is, at the end of the day, a yes or no all the time decision. And so we're talking about attempting to artificially resuscitate somebody when both your heart and your lungs have stopped. Both of those things have to be true for us to even consider whether we're attempting CPR or not. And as you can imagine, in that sort of situation where your heart and your lungs have stopped, we would always consider that a medical emergency. And we need to know, are we attempting to resuscitate this person, or are we not trying to attempt to resuscitate this person? The default decision that has been made for you if you've not signed a do not resuscitate form is we will automatically attempt to resuscitate anyone without that form. Again, it's one of the few times in the medical field where if you don't want us to do something to you, you have to sign something and have your doctor sign something saying, do not do this. The default is to always attempt. Yes? Yeah, the term code status, it really is kind of the overarching kind of term we use to say, this is the decision about when your heart and your lungs have stopped, what would you like us to do? Yes. Mm-hmm. Yeah, some of it is terminology. And so the code status, it's really, am I a do not resuscitate? Sometimes if you are, you would be considered a full code if you do not have a do not resuscitate order on file. And so again, I could go into a lot of detail about code status. I believe on one of the handouts, there is some information about a website you can go to about code status. Certainly, if you have questions during the Q&A today, I'm happy to go into any of that. But code status, it's just an example. This is a choice that you have full control over making. You might not have all of the information you need to make that decision. And so again, our Care Connections program wants to make sure you have the information you need to make the decision that feels best to you. Everyone can have a different opinion on code status, and there's really no wrong answer for code status. Some nurses and some doctors may present it in a little bit of a different way. However, from the social work perspective, as long as you have the information you need to make that decision and you feel okay with that decision, it is completely valid, and we will honor that as the organization potentially providing that medical care in that situation. I will say, when we talk about code status, it is hard to present some of the facts and the statistics about it and not feel a little bit biased. But again, in the spirit of giving information, you know, some of the statistics will say that for people over 65, the success rate for CPR or resuscitation is about between 5 and 10%. And so if you don't know that statistic, you might have a very different opinion about code status. If you hear that and say, well, if it only works for 5 to 10 people out of 100, I might need to rethink this, or I might need more information about this. This is really where the conversation starts, just to say, what do you already know? What do you need to know? And once you have made a decision you feel comfortable with, are we documenting that appropriately so that anyone in this building who might be responding to you in a medical way knows immediately this person is do not resuscitate or this person is full code? And we kind of are able to kind of shape our response based on that. Yeah, no problem. Yeah, great question. The difference between do not resuscitate and full code is the medical response. So if your heart and your lungs have stopped and you do not have a do not resuscitate form on file that is signed by your physician, which is an important part, we are legally required to attempt to resuscitate you. So that is the chest compressions. It might include artificial breathing. It's all in an attempt to restart either one or both of those systems that have stopped, right? And so a full code basically means we are attempting that resuscitation. Do not resuscitate means just the opposite. This person's heart and lungs have stopped, but they have signed something with their physician saying, when these two things are true, when my heart and my lungs have stopped, I do not want you or any medical professional to attempt to resuscitate me. And that is absolutely your choice. Just a little tidbit, and a lot of nurses, when they talk about code status, will bring this up. If your heart and your lungs have stopped, what may that mean? Your brain is affected. You've passed away. You cannot survive without your heart and your lungs functioning, right? And so CPR is attempting to artificially restart one or both of those systems. If it is successful, let's say you're part of the 5 to 10% of people that it's successful for, you will immediately go to the hospital, right? Because the CPR doesn't fix whatever got you to that point. We've just kind of temporarily restarted those things. And again, I'm a little long-winded on code status. I really can talk about it for a long time. However, if we're talking with someone and they say, I am generally trying to avoid the hospital, I definitely don't want to go to the ICU, but I think I might want to be a full code. We really want to talk through that and play that all the way through to say, if you choose to have us attempt resuscitation for you and it's successful, you will immediately go to the hospital and likely to the ICU, because we really have to figure out diagnostically what happened to get you to that point. Can your body sustain those functions independently, or do you need to be on a ventilator or a cardiac machine? And so a lot of these details, in this example of code status, this is how we really end up having some very long conversations. This yes or no determination on your part, really, there's a lot of information that goes into it. On the handout as well, there's a resource for what we call the POLST form, POLST. It stands for Physician's Orders for Life-Sustaining Treatment. And if you go and look at that form, it's free to download. Similar to the Do Not Resuscitate form, it's a medical form. So if you complete it, it does need to be signed by a physician as well to become a medical order. I really find that form super helpful. Even if you don't complete it with a physician and make it a medical order, it really does a nice job of outlining some of the medical decisions that you might not have thought about already. Or, the middle section, the top section of that form is all about code status. It's either yes, attempt resuscitation, or no, don't attempt resuscitation. There are some other things on the form that talk about artificial nutrition and hydration. We can add things in about hospitalizations and hospice. When we're talking about general medical goals for care, sometimes it's hard to know where to start. The middle section on that POLST form does a really nice job of kind of separating into what I call like the 3 buckets of medical care. One is full interventions. I am open to absolutely everything. I'm open to resuscitation, the ICU, any medical intervention that's recommended to me. I at least want to try it. And again, that is totally valid if that's how you feel. On the opposite end of the spectrum, we have comfort measures, which really leans us more towards palliative care and hospice when we're saying, if I have a chronic illness that I either know there's not a treatment for, the treatment that is available I've tried and it was not successful, or I just don't want to try the treatment that's available, we may be talking more about comfort care, right? There is a middle section too, kind of in between those two extremes, that is what we call limited additional interventions. So we're not all the way on the side of wanting every intervention, but we're not quite at the point where we're solely looking for comfort measures. That is generally how our medical field reacts anyway. It's kind of problem focused, right? We will identify the problem. You will walk through with your physician what the options might be for treatment, and you kind of take things as they come. Again, even if you don't fill out the form, this can be a really helpful guide to say, which of these three buckets do I connect with most at this time? It's really helpful in kind of a conversation starting way with your family, your medical powers of attorney, to say, hey, I've really thought about it. I might have met with the Care Connections team. These are the things that we discuss, and this is what I'm feeling right now. It can be a really good guide to say, at least kind of divvying up into one of those three buckets. It also helps us kind of understand what resources we might guide you to. For people that are looking for comfort care, we are often talking about hospice and eligibility and criteria to say, if you're looking for comfort, hospice is the best way to accomplish that. Let's explore if you might be eligible for that if you're open to it. Yes. Sure.
Excuse me. So if I pass out and I'm down in the bowels of the building at the parking lot or something like that, and I have a DNR on file, well, somebody's going to call 911. Okay, and I don't have DNR tattooed on me anywhere or anything like that. So they're going to attempt to revive me, correct?
Yes and no. And it's very interesting you bring up the tattoo. In the state of Virginia, that's actually not even a legal way to have a DNR kind of established either. There is, on the resource sheet too, it always sounds a little silly to talk about. Virginia does participate in a Do Not Resuscitate jewelry program, where if you submit your completed Do Not Resuscitate form signed by a physician, you can get a necklace, a bracelet, or an anklet that says essentially that, the number of the medical order and a Do Not Resuscitate. For in the community, again, it might not sound like the prettiest piece of jewelry to wear. It is the most effective way to ensure that if you've decided Do Not Resuscitate is your preference, that is the best way to have that kind of recognized and honored out in the community. Now, within Goodwin Living, it's a little bit different. If you pass out in the garage here, we have medical providers here. They will likely be the first people to respond to you here. They have automatic access to your medical record here. And on your, what we call the face sheet, the first sheet that pops up when we click on someone's name, your code status is listed right there. So it's a very immediate thing where we can know this person has a signed Do Not Resuscitate order. It's already on the file. If we receive this person, their heart and their lungs have stopped, we are not attempting resuscitation. Does that make sense?
It does, but what if you elect not to have a DNR?
Well, because the default is always to attempt, if we don't have the Do Not Resuscitate form or that order on your file, we will automatically begin to attempt resuscitation.
The thing that bothers me is the time lapse. By the time, someone's, well, check his DNR form. How readily available is that? Like here at Goodwin House, the clinic is manned 24/7.
Yep, exactly. So let's say it's after hours and someone, one of a Goodwin Living staff member is the responder. They will look in your chart to look at your code status. We always encourage people, if you have a Do Not Resuscitate form, we talked about the jewelry as being kind of your line of defense in the community. In your home, whether it's a Goodwin Living responder or an emergency responder, they are always trained to look on the back of your front door and on your refrigerator to see if there's a sign, "Do not resuscitate" form. So they will always look in those places first. Similarly to the jewelry, it's a bright yellow piece of paper most of the time. It's not the most attractive decor, but if it serves a real good purpose for you, if you know that you don't want resuscitation attempted, having that ready and visible is a really good way to make sure that that decision is honored. Yes, I'm just going to go over one more thing first. I want to make sure that Jen has a couple minutes to just introduce everything she's here to talk about. We are leaving intentionally a lot of time at the end for Q&A, so we will absolutely get to all of your questions. The last thing that I will say is about hospice and hospice utilization. We talked about how you do have to meet the criteria for hospice to be admitted and be eligible. Anecdotally, most of the people that we work with that end up on our hospice service will often say, "I really wish I would have done this sooner. The support that I got from the team, the support that I got from my family has been really helpful." And so I just want to make sure everyone knows we can do what we call a hospice eligibility assessment at any time. You don't have to have come from the hospital. You don't need an order from your physician. Our hospice admissions team can look at your medical record and determine whether we believe you're eligible for hospice or not at any time. And so if that's ever of interest to you, you can contact me. My contact information is on the handout as well. That is something that is always available to you. It does not automatically sign you up for hospice if you are eligible. In the spirit of giving you the information you need, it lets you know, yes, I'm eligible at this time and I can decide from there, or no, I'm not eligible right now, and we'll just keep kind of following along with you at that point. I want to give it over to Jen right now. I'm speaking a little long. Jen's going to talk about some legal things that I know some people are clients of hers. She's got a lot of great legal knowledge. I'm going to give it to her for a little bit, and then we'll open up for some more questions, okay?
Thank you, Aaron. I love coming and presenting with Aaron because I learn something every time. In fact, our documents were updated to include POLST information because of what you taught me 2 years ago. My name is Jen Crane. I'm the Director of Fiduciary Strategy for Chainbridge Bank. That's a very fancy way of saying I review estate plans to find holes and problems. And one of the biggest holes we see is someone will say to me, "I need my healthcare agent to be accessible because if I collapse, I need the paramedics to be able to reach them." Aaron, are the paramedics ever going to call the agent under the healthcare POA? No, they're going to do one of two things: start saving your life or look for the DNR. And it's really important to know the differences in what the documents can do. In the healthcare space, you have a healthcare power of attorney, an advance directive, which is the same thing as a living will. A healthcare power of attorney is where you name agents to do things for you if you can't do them. The living will is where you say, "Don't keep me alive if I'm dying." If you're in the hospital, your advanced medical directive or your healthcare power of attorney is going to be the document that governs your care if you're unable to make decisions for yourself. But they have very discrete purposes, and understanding what everything can do matters because it is a terrifying thought to think you have everything in order and you find out, well, I may have everything in order, but there's a gap. Something's missing. Or I've told my agent what I want. I don't need to worry about it. No, you do need to worry about it. You need to write down what your wishes and intentions are. I'm going to say, and correct me if I'm wrong, I've never seen medical personnel do much with the medical power of attorney other than make sure it's valid. No doctor is going to say, "Johnny, is this really what your mother wanted?" They're going to trust that you've had those conversations. And nobody wants to have those conversations. Who wants to talk about death and dying? Other than how, enigmatic and charming you and I are, it's not a topic we want to discuss. But the greatest gift you can give the people that you love is the conversation about what you wanted. So making sure you have a healthcare power of attorney that's valid in the Commonwealth of Virginia, that means it's witnessed by 2 people, that gives your agents powers to do things and includes a living will is critical. Then having the conversation about how you want your agents to use those powers on your behalf. Every time I do this, and I teach health law for William and Mary, imagine trying to teach this to college students, I always say you have to pick an agent who will do what you want done, not what they want to do. For those of you who have had to listen to me drone on before, this is where I say my beloved mother will never be my agent because I will be the bionic woman. I will be the Terminator. She'll never let me go. And that's not what I want. We have to pick people who will do what we want. All estate planning is about control. What do you want? Who's going to carry out your wishes? Because a healthcare power of attorney, at the end of the day, speaks for you when you can't speak for yourself. Now, I want to hop back briefly to something Erin mentioned that has been life-changing in estate planning, and that's the POLST. Because the majority of people I serve are solo agers or couples that don't have children. And they worry more than most about having somebody to make decisions. What if there's no agent? Because your healthcare power of attorney doesn't work. It has to have shoes to carry it out. If there's no agent, it's not worth the paper it's written on. But a POLST, it's a doctor's order. It carries, right, a signature. And am I correct that if someone is taken out to the hospital, if they have a POLST, it's going to be with them? He's saying I'm right.
Yes, and kind of in 2 ways. Our staff here is trained to print out any and all advanced directive documentation when someone is transferred to the hospital, and they physically hand it to whoever's transferring you to the hospital. The POLST form also has a national registry that you can and should upload that form into that is accessible by any hospital in the country.
It's critical to do those things because what if we can't get a hold of your agent? What if it's the middle of the night and they're hiking in the Amazon? The POLST can still speak for you, and it's an amazing tool. We're looking for control when we won't have a voice. So why not have as many tools in the toolkit as we possibly can? That's how we keep control, and that's how we give the gift of comfort to our loved ones. Yes, sir.
I have heard that the POLST is not valid unless the physician has specified that you have no more than 6 months to live.
Question was, I have heard the POLST is not valid unless the physician has certified I have no more than 6 months to live.
Not exactly. Most physicians would prefer to sign a POLST form for someone that is kind of making their final medical decisions. And so a lot of times when we admit people to hospice or when we're talking about hospice, we use the POLST form as a tool to say, let's make sure that everything we've talked about in terms of your choices translates to a medical order. However, you can fill out a POLST form really at any time. What we would encourage you to do, and this is the hardest part to keep up, is that let's say you're one of those people that says, I want absolutely everything, and that's how you fill out your POLST form. If at any time in your health journey that changes for you, you have to do a new POLST form so that it's representative of how you feel. And if you are the one that is signing your own POLST form, you are the only one who can change that POLST form. And so it's just really important to keep up on that. For the challenges of someone with cognitive decline, signing a POLST form with anything more than comfort measures becomes a little bit tricky, because at some point they may not have capacity to make that decision anymore. And so reversing what you have established on your POLST form becomes a little bit tricky.
We can put in medical powers of attorney, we can give an agent the authority to agree to a DNR or to agree to a POLST, but the hiccup is medical powers of attorney are not valid until you've been certified to be incapable of making your own decisions, because nobody should be making medical decisions for you as long as you're capable of making them. So if I'm my mother's agent and I need to do a DNR, I can't get the power to do that till we get through the incapacity declaration. What would have been better is if mom did the DNR or mom did the POLST, because mom is also, it's her life and her care. I'm guessing. My father was blissfully clear. I want to be carried out of the house feet first, Jen, nothing else. You got it. But he didn't have a DNR. So the paramedics had to take him to the hospital. Doctor had to declare him incapacitated before I could say, please stop the life-sustaining measures that have been going on for the last 3 hours, because he didn't have a DNR. We have to have the documents the law gives us. I will be the first person to knock the Commonwealth for the confusing nature of our laws. I firmly believe that because most of our delegates are lawyers, they make it as confusing as possible in the name of job security. But we got to get past the confusion and use the tools we've got, because would you rather say what you want through a DNR or a POLST or a medical directive, or default to what the state wants, which is life-sustaining measures? So knowing what you want, knowing how to execute it, you have to be an active part in your care, which is how you maintain control. Now, the one thing I want to mention, Aaron has talked about, we can update DNRs, we can update POLSTs. As long as you are legally capacitated, you can update your power of attorney. Jen, I don't want to pay a lawyer to update my power of attorney. I'm just going to cross through the sections I don't like anymore. That's valid, right? No, it's not. We have to consider the entire document revoked. Now, there's one tidbit between the last time we presented and now that keeps cropping up. Powers of attorney are only effective during your lifetime, because in a power of attorney, if Aaron is my agent, I'm the principal, I give the power to act on my behalf to my agent. Agent, I have to be alive, right, in order for that power to work. If I'm dead, as my son would say when he was a baby, it no work. But, there are 3 powers that supersede death in a healthcare directive: the authority to authorize an autopsy, organ donation, and the biggest one of all, authorize for the disposition of your remains. One of the things I deal with the most frequency: person dies at the hospital, they've been declared dead. What do you think the hospital administrator calls me and asks, Aaron? What do you do with the body? Who's got the authority to take Mrs. Smith? I know when my phone rings on a Saturday morning, it's Inova trying to figure out who has authority. Because if the medical power of attorney doesn't include that, nobody does. Now, if you've prepaid your funeral and burial arrangements, I beg you to call the funeral director and make sure the disposition of remains, power of attorney, was done. Because you can have the grandest funeral planned. We can have, what is it, a Mardi Gras funeral? And if no one has the authority to get your body from the hospital to the funeral home, welcome to my life. This is what I chose to do for a living. We're out of luck. So that power's got to be there, and that's critical for two reasons. If you've moved here from out of state, your medical power of attorney may not include that. Now, your power of attorney, say you came from Maryland, Commonwealth of Virginia has to give it full force and effect. We have to accept it, but Maryland may not have that provision. It's absolutely critical to check and make sure when you move, all of that information is in there. I always tell people it's cheaper to pay a lawyer to redo the document than to fight about it later. But on top of that, you want to make sure that the way we honor your wishes transfers over as well. Because oftentimes, second thing, for lack of understanding, maybe it's because attorneys like to print a lot of paper, they'll do an advance directive, they'll do a separate living will, and then they'll do the healthcare power of attorney. And there'll be the fourth one, the HIPAA authorization. There's 4 documents that could all be one. And why do we want them all to be one? I tell people that when my dad died, I'd been practicing for 9 years. I was a baby. It was back when God was a child. I got lost in the courthouse trying to find the probate division because grief and stress do terrible things to us. We want to make sure that if there's a call, mom's collapsed, we need you to get to the hospital. If I'm diving through mom's estate planning binder, am I going to pause to carefully check each document and make sure I'm bringing the right one? No, I'm going to grab the first thing that says health on it. And if you had to guess, which one do you think they come to the hospital with?
The HIPAA?
The HIPAA. Every time they come with the HIPAA. And then we have to get the document scanned and over, which isn't a problem, but we're losing time. So being able to have control over your medical decisions means taking control. We take control legally by making sure we have valid documents that name the agents who will do what we want done. We make sure they're valid. We make sure we know where they are. That's also important. And we look at them every 2 years or if there's a major medical event. Because otherwise, we're just leaving it to chance for somebody to try and figure out. On that super depressing note, questions? Thanks for raising your hand.
When you say agent, could that be a relative, or is an agent only a relative? I mean, only someone you hire, or is it possibly a relative?
That's a great question. Your agent can be anybody over the age of 18 who's willing to do it. It can be a relative. It can be a care manager. It can be a fiduciary company. We have a lot of options there, but I have a few words of warning about selecting an agent. Please don't grab the closest living, breathing relative because they may not be a good fit for what you need. I tell this story every time. My mother and my sister are estranged. And about 2 years ago, my mom said, Jen, I want you to update the documents. I want you and Steph to be co-fiduciaries on everything because that's what's going to bring her back. No, it's not. It's going to make me resign. Pick people who can handle the stress of making a medical decision. A lot of people kind of throw away the medical agent. They pick one person for the financial, and then they compensate and give the other child the medical because they think it's the easier job. I don't know about you. I think the medical is the way harder job, way harder. So somebody who's good under pressure, can take information in, and is not too young to take on the task. Just because an 18-year-old could do it doesn't mean an 18-year-old should do it. There's no requirement it be family or a child. If your best friend knows you best, name your best friend. Name a couple backups. Don't ever do a couple backups. Don't ever do a power of attorney with just one agent. Because if that one agent is unavailable, does the power of attorney do me any good, Aaron? Nothing. It stands there. Just, it does nothing. Not even worth the paper that it's written on. So backup agents, please.
A lot of people that we meet with when we're talking about either establishing a healthcare power of attorney or updating it, there is kind of this idea that, well, if I'm married, it has to be my spouse, or it has to go in kind of birth order. It does not. I'm the youngest of 3 boys. My middle brother is a math teacher. He is the financial power of attorney for my parents. I am the youngest. I'm a medical social worker. I am the medical power of attorney for my parents. It does not have to be somebody that is closest to you, as Jen said. And as Noelle mentioned too, it should be someone that you can trust to make the decision that you want, even if they don't agree with it. You could be saying to someone, I want to do not resuscitate. And if you have a friend who you're considering and they say, oh, well, that's a terrible decision. I'm full code. I think everybody should be full code. Maybe your alert should go up and say, maybe that's not my person. And that's okay.
And that's okay. Yes, ma'am.
Say you were my medical, say you had my medical power of attorney.
Yes,
Do
ma'am.
people call you all times, day and night?
I'm a crazy person. And so I give my cell phone number out because I tell people if you call at 2 a.m, Apple gives me the technology to block you. But when there's a medical, my oldest in time and duration client died. He was at Green Spring. He had served in every modern war. He was a tremendous, tremendous man. He and his wife had no children. And so he asked if I would be his agent. I made sure I knew every single thing he wanted, stayed in enough touch with him. So when he said, Jenny, I just want to go. Jack, are you saying what I think you're saying? Let me go. Got it. Because your agent has to know you well enough to be able to make that decision. But when we pick our agents, we pick a person who will do what we want done, not what they want to do. If you have wildly different religious beliefs, generally not a great idea. If you do believe in life-sustaining measures at all costs, not a good idea. And if the person can't have the conversation with you, not a good idea. Well, and so there is the question of burden, and that comes up all the time. When we are helping families select their fiduciaries, agents, executors, trustees. Oh, we did black and black. Noelle, I just noticed. Aaron, you missed the memo. When we are helping, we always say pick the person who's best for the job. We show people we love them by giving them money, not by giving them a job they can't do, which is true. It's not a burden if the person loves you. If the person loves you, it is an unequivocal yes. Of course I will. Because being an agent, if I can ask if people are comfortable, who's been an agent before? Isn't it one of the hardest but most beautiful things you've ever done to speak for somebody when they can't speak? It's awful. It was awful because I did not want to lose Dad. I wanted them to keep him plugged into that wall and everything was going to be fine. But he didn't want that. And every time the Washington transplant, he wanted to be an organ donor. He had had Hodgkin's disease. He wanted to be an organ donor. I said, Daddy, I'll do my best. And they called and they said, we can use his skin and his shin bones and his corneas. And I said, do it, because that way he gets to walk out here. One of the hardest things I've ever done. I'm getting goosebumps talking about it. But it's what he wanted. And I kind of love the thought that maybe one day I'll run into somebody who's looking at me through his eyes. But it's because I could do what he wanted done. So it's not a burden to a person who loves you.
Yep, and I'll jump in and second that. We had this conversation with my parents a couple years ago. I have 2 other siblings, and it's not an easy conversation to have. I mean, no one, like you said, wants to have it, but they actually said they picked me as the medical power of attorney, or because I was the one who decided to euthanize the dog, the family dog. Well, he was, so they're like, we know she can do it. And that's just a funny aside. But to your point, Jen, my parents are very clear about what they want. So I don't feel like it's a burden because I don't have to make those decisions. And I watched them suffer with trying to figure out what to do with their own parents because they didn't have anything written down, and they're still wondering if they made the right decision. So having that clarity is no burden. It's a real burden to have none of this put down.
And
That's
just-
what, oh, I'm sorry, go ahead.
Just to add to that, and it's a shameless plug for the Care Connections program, if you need support having that conversation with your family, with whoever you're thinking about picking, with who you've already picked, but your choices are maybe changing, we are happy to have those conversations with you. We do it in all settings and every level of care. We do it at the hospital with people. We are here to really advocate for you and help make sure that that conversation goes as you would like it. And sometimes it's just nice to have some extra support in there, having these conversations that are not the most pleasant.
Your medical power of attorney lists authorities. It does not list specifics. That's why I gave you this incredibly grim worksheet on thoughtful conversations, the things that you should talk about. Write a letter in your own handwriting, don't type it, to your agent about what you want and what you don't want. Because Erin, correct me if I'm wrong, no doctor's going to go through the healthcare and be like, oh, I see mom didn't want chemotherapy if she had a 70% likelihood of recovery. They're not going to do that. We're going to give your agent every authority allowable, and in that letter is where you list what you wanted. Now, Virginia does make a statutory healthcare, or they call it an advanced medical directive available. The only thing I will caution you about the form, and the form is better than nothing, it doesn't have a disposition of remains provision. So you got to print that one off separately. Please print the separate one off. Otherwise, I'm going to get a call on a Saturday morning. Let's do some questions.
Here, let me bring you the mic really quick.
I've got two questions, but I think they're both short. One is, I am my husband's second wife, and his medical power of attorney lists me and both of his kids.
At the same time?
Any one of whom may act independently. Is that a
Okie
good idea, or
dokie.
is that a
I'm
problem?
moving over to you. Let's sit down. I do not love, so number one, you can do, as long as a person is capacitated, they can make any choice they want. And there's a reason the Supreme Court has 9 justices. I would have told a client, no, can't name 3, and you can't give any one of them the power to act. Because if 2 of them come in with separate, conflicting directions, I believe the doctor's going to say you got to get a judge to decide. We're not going to take instruction from any of you. Unless it is the Brady Bunch and everybody can, sing and dance in unison. What was that family from the 70s? Not the Brady Bunch.
Partridge Family.
Thank you, the Partridge Family. David something. Unless you guys can do that, that worries me because it's a lot of cooks in the kitchen. A lot of cooks in the kitchen. Do you have a second question?
Yes, and I think I maybe just missed something that you said when you started out saying there were 4 forms. Wouldn't it be better to have one form?
Oh, dear God, yes. It should only be one form. But some lawyers, I can give you a list later, do them as 4 separate ones. You want it all together.
No matter what the title is, as long as each of those.
Oh, it matters what the title is.
Okay.
The title should be healthcare power of attorney because you can put everything else inside it. The thinking behind separating the documents is maybe you don't want your information being placed if it doesn't need to be there. For me, the greater risk is you show up to the hospital with the wrong one. Thank you.
What if you just fill out the form and say, do not transport from here? What happens to you then?
That's a you question.
Yes, the do not transport is similar to the do not resuscitate or the POST form. It is less of a legal document and more of a medical order. When we are talking to people about hospitalizations, it's not uncommon, especially for people that are advancing in a chronic illness. They may say, I don't ever want to go to the hospital. I know it's not going to change the outcome of my disease. I don't want to go. We can put in a medical order that has to be signed by your physician that says, do not transport. The thing I will caution about that kind of blanket order is that that states in no uncertain terms, do not transport this person ever. And that might be the case for some people. What I always like to say, and playing a little bit of devil's advocate, if you know that going to the hospital is not going to have a positive outcome on your chronic illness, that makes sense for you. There's always the possibility of an acute event happening. We always talk about, if you unfortunately fall and you might have broken your hip or your femur, that is something that you might feel differently about. That type of hospitalization might feel different than going for a COPD exacerbation. And so what we can do is be thoughtful about how we write that order and say, do not transport without either the resident or the medical power of attorney's approval. And what that does is it covers you either way. If you are not deemed incapable of making your own decisions, that order then says we cannot transport you unless you, as the resident, the patient, gives us the authority to do so. If you are deemed incapable of making your own medical decisions, that power is deferred to your medical power of attorney. We would not be able to send you until we get in touch with that power of attorney and they say, yes, in this situation, I would like them to go to the hospital, or no, this is a situation where we do not want to transport. It can be. There is a write-in section on the POLST form where we can dictate some additional medical orders. It's one of the ones that we often talk about in hospitalizations. The other thing is for hospice. If we are filling out a POLST form with someone and they are really kind of leaning towards comfort measures and they want to be admitted to hospice when they're eligible, we can write in a medical order that says just that. Admit to hospice when eligible, so that process hopefully moves a little bit more swiftly at the time when you become eligible. Some people are looking for comfort measures but don't quite qualify based on the Medicare criteria to be admitted to hospice. Having that written on the form says to your providers, someone has had this conversation with me. We've decided that at any point when I become eligible, we would like an immediate admission to hospice.
One other thing, there was a comment in a New York Times article that I don't know if it would be valid in Virginia or not, but a physician said we all need to put on the forms no needles so that you have no needles, no IVs, and nothing happens to you. And that's a limitation that helps you at the end. Is that
Interesting.
something you're familiar with?
I haven't heard of that, no. It's an interesting thought, though. It definitely aligns, I would assume, more so on the comfort measures where we're not doing anything restorative or curative, whereas putting in an IV for antibiotics or pushing fluids in through the veins.
That's
maybe
the idea, to do no changes whatsoever. You're just there.
I can wrap my head around it. I haven't heard of it, though, but that's really interesting. Thank you for bringing that up.
Coming to you.
Yes, I've been here 3 years and I've never heard of Care Connections before.
Oh, no.
True. And could you tell, where are you? Who's allowed to come see you? And what exactly beyond what you talked about today do you do?
Yeah, those are easy questions for me to answer. We are everywhere. We go between all three of the buildings. We see people on all levels of care in all three of our campus locations. So any resident is able to access our services. There is no charge. We don't bill your insurance. This is really just kind of a best practice that Goodwin Living really believes in. So anyone can meet with us. Oftentimes, we'll meet with people kind of specifically around the documents that we've talked about today. Other times, we will talk about your specific disease diagnosis and your progression to kind of identify and steer you to the resources that make sense for you. We can do that all together as well. We can do both of them. And so we don't have any dedicated office space because we're kind of running around all day. But we can meet with you in your apartment. We can, rent out a room in whatever campus location you live in. If you would like to meet with us, you just let us know and we will come meet with you.
Yes.
Yeah, absolutely. We do some advertising in the Gazette and in the other newsletter at Bailey's. We will make sure that we're kind of up on that. We try and do these talks at least every couple of years, and I do at least one town hall a year at every campus location. So I did one this past year too, but yes, we will make sure that we want people to know about us. It is also job security for us as long as we have people calling and saying, we would like to meet with you.
Yeah, and his contact information is on the bottom of the resources page.
Yes.
And I know that it is a priority for Goodwin Hospice to really grow this Care Connections program because it is so valuable. So hopefully you will be hearing much more about it.
Can I brag about Aaron real fast and how much I learned from him 2 years ago? I had a mother brought into a consult by her son, mandating some changes to her medical power of attorney. And she wanted to do what he was telling her to do so he'd go away. And I said, I can't do it for you. But where do you live? I live at Goodwin. Go see him. Do a post. And it was magic. It was magic because the post dictated everything she wanted. And from that moment on, anybody in any facility, do a post, find a social worker, learn about it, because it's a tremendous tool and it doesn't get the publicity. And the fact that Aaron was ahead of the curve, knew it, taught me, and I'm hard to teach. It's an invaluable resource.
Yes.
I'd like to ask you, I think I've done most of these things. I've even had you up to my apartment for this. My question is, who do I call to make sure that everything is still the way I want?
Me.
Can I have your card?
We'll be happy to see you afterwards. Anybody, I want to throw one quick question back when you were asking about agents, because it just popped into my brain. I've been recommending for some folks who don't have an appropriate decision maker using a care manager as their agent. What are your thoughts on that?
Care managers can be extremely helpful, and they tend to be, I don't want to say they all are, they do tend to be available pretty much 24/7. The financial implication of that is sometimes the decision maker, right? You know, you are paying for care management. They have an hourly rate, you know, depending on what time they're spending with you. If they're taking you to the doctor's appointment as opposed to meeting you there, if they're taking your call at 2 a.m. So there is kind of a financial component to care management, but anecdotally, a lot of people that have used them have had really good experiences. If it's also for a care management group, so someone that's not an independent care manager, there are some kind of built-in automatic backups if that person happens to be out of town or on vacation. Those are kind of your built-in successors to your medical powers of attorney.
Just to make sure I mention that. It's another way.
And let me just say to your point too, if you have questions about what documents are on file at Goodwin Living, you can let me know. Depending on whatever level of care you're on, you can ask your social worker. Monica is incredible in independent living. Obviously, Hillary and Kylie can look up the same things too. There is a tab on everybody's electronic medical record that we can easily click and say, this is what's on file, this is what we don't have, and help you there. Yes, we have everything that you've given us. So I know a lot of times when you
That's different.
when you admit or when you're first moving in, there's a lot of things that we're asking for in terms of paperwork. You can let us know. If you don't know if you ever gave us your medical power of attorney, shoot me an email, give me a call. I can check for you in real time. And if we don't have it, sometimes it's a matter of it's completed. We just don't have the copy. And that's easy. If you need to do a whole new document, we can help with that too.
And update it. If you work with your attorney and update the document, please give it to Goodwin, because if they've got the power of attorney from 1984, that's the one they've got.
All right, so we do have to wrap up. We have another panel to run to, but I want to thank you both because this is so valuable. Do you think if there was one thing people should do right away, would you say it would be the post?
I would say you should certainly take a look at the Pulse form. The website is on one of the resource pages. I always say if there are things you know you definitely don't want, resuscitation is a great example. If you know you don't want that, fill out a do not resuscitate form or fill out the Pulse form that it's included on. a lot of times the medical field will automatically try things because they think it might be helpful. We are kind of working backwards, right? We're saying from absolutely everything, what are the things I don't want? And how do I make sure that that's listed clearly and concisely on that PULSE form?
Okay, great. And Jen brought a new form, and this has her contact information on it.
It's just a fun estate planning potpourri because, you know, I bring fun and laughter everywhere I go and I knock things off
But it
the
does
wall.
have her contact information. And I know she has happy clients here. Huh? They're right at the outside, and there's some chapstick as well. Let me see if we can get one more question while we're leaving.
I have a question for you, and that is, I've been asking, I haven't done it in the last year because I've solved the problem, for a list of estate planning attorneys. And Goodwin Living, at least Alexandria, I've been in the sales office, they have no list. And I just think it would be to the advantage of somebody to put together a list of viable estate planning attorneys.
Yes, that's a great point and well taken. As a social worker, I am not allowed to specifically recommend, but I do understand your point, and that is something an executive director could absolutely say, let's put something together and keep this on file. So
Yeah, I'm not even talking about recommending. I'm just talking about putting together
just who's
and then
available.
going over a list.
yeah, absolutely.
You can also, I tell folks when they can't find a lawyer, pick 3 that are in the area, interview them. If they won't talk to you for free for 15 minutes, you don't want them.
All right. Okay, well, thank you, everyone, so much. This is really informative. Again, grab the extra handout on your way out, and we'll be back with more information, I'm sure, soon.